have probably seen like all those wellness ads popping up on your social media feed lately.
Oh, definitely. They're everywhere.
Right. And they feature these super calming, aesthetically pleasing clinics, and they're promising a 10-minute fix to some of your most private, intimate frustrations.
Yeah, the marketing is incredibly effective.
It is. I mean, imagine losing a profound source of physical pleasure you once had. Or perhaps you spent your entire life feeling like you were missing out on an experience that everyone else just seems to have naturally.
Which is a very isolating feeling for a lot of people.
Totally. Now, imagine walking into one of those clinics and being told that a simple cosmetic injection could just fix everything.
It sounds incredibly tempting, doesn't it? I mean, we are culturally conditioned to look for a quick, binary fix to what is actually a deeply complex human experience.
Exactly. But we really have to ask, like, is this a medical miracle? Is it just a clever marketing gimmick? Or is it something floating in that murky water somewhere in between?
It's usually the in-between, right?
Always. So today, our deep dive is tackling a highly debated, heavily marketed procedure known as the G-shot, or G-spot amplification.
A very controversial topic.
Highly controversial. We're zeroing in on a very specific question for you today. Is this injection a viable treatment for women with a history of primary or secondary anorgasmia?
And honestly, if someone actually goes through with it, what are the realistic outcome goals?
Right. And to figure it out, we've pulled together a massive stack of sources for you. We were looking at clinical psychology texts from UT Labs, official statements from the American College of Obstetricians and Gynecologists.
Which is a major authority.
Huge. And I'll just refer to them as ACOG for short.
Yeah.
We also have international medical journals. But we aren't stopping at the academia.
No, we really can't.
Right, because we were also looking directly at the promotional materials and the websites from the cosmetic plastic surgeons and wellness clinics that are actually selling this procedure to you.
And I have to say, the contrast between what those medical journals state and what the cosmetic marketing materials promise is, well, it's going to be incredibly revealing.
Okay, let's unpack this. Before we even get to the injection itself, we really have to understand the condition it claims to treat.
Right, the baseline.
Yeah, because I see the word anorgasmia thrown around in these clinical texts constantly, but how are they actually defining that in a medical setting?
So the formal clinical term is female orgasmic disorder.
Yeah.
And at its baseline, it's defined as the persistent or recurrent delay in or complete absence of orgasm following a normal sexual excitement phase.
Okay, that makes sense.
But the crucial piece of the diagnostic criteria, and this is very important for how doctors actually approach it, is that it has to cause marked personal distress or interpersonal difficulty.
Wait, really? So if a woman doesn't climax but she's perfectly happy with her sex life and feels a sense of intimacy anyway, clinically, there is no disorder to treat?
Exactly. Distress is the key metric here. If you aren't distressed, you don't have a disorder.
That is fascinating.
Yeah, and our sources break this distress down into two main categories. You have primary and secondary.
Okay.
Primary, which is also called lifelong anorgasmia, refers to women who have never experienced an orgasm under any circumstances.
Not through intercourse, not through masturbation, just never.
Not ever. And that affects roughly 4 to 10% of women.
Wow. And then there is secondary or acquired anorgasmia. From reading the texts, this seems to be where a woman used to be able to climax, but for some reason, the system sort of stalled out and she lost the ability.
Yes.
And that is much more common, right? Affecting about 20 to 30% of women.
It is much more common. But here is where we need to introduce a critical statistic from the medical literature, because it completely reframes how we look at this so-called dysfunction.
Okay, lay it on me.
70% of women cannot achieve orgasm through vaginal or penile penetration alone. They require direct clitoral stimulation.
Wait, I have to push back on the terminology being used in these clinical spaces then.
Go for it.
If 70% of women require direct clitoral stimulation to reach climax, then struggling to climax solely from penetrative intercourse isn't a dysfunction. That is literally the biological norm for the vast majority of the population.
You've hit the nail on the head.
Like, why are we medicalizing normal human anatomy?
You are bringing up a massive debate within the sexology and gynecological fields right now. Many clinicians completely agree with you and argue against medicalizing it.
Because it's just normal.
Right.
Yeah.
But the counter-argument from the psychiatric side is that if a patient comes in deeply distressed because her specific goal is to achieve climax through intercourse alone,
Oh, I see.
Yeah, dismissing her psychological pain just because her anatomy is technically normal isn't providing helpful care.
Okay, that makes sense.
Yeah.
So they classify it differently to acknowledge her distress without basically calling her body broken.
Precisely. They classify it as situational or coital anorgasmia. The doctor acknowledges it is perfectly normal biology, but they will still work with the patient to try and achieve her specific goals.
That distinction is huge for anyone listening who might be dealing with this. So if we look at the women who are genuinely experiencing a dysfunction, either they've never had an orgasm or they lost the ability, what is actually happening under the hood?
Well, what causes the system to stall out?
Yeah, exactly.
The roots are incredibly varied, but let's look at the mechanisms. On the physical side, medications are a massive factor. Selective serotonin reuptake inhibitors, or SSRIs,
Those are very common antidepressants.
very common, and they cause orgasmic issues in 15 to 35% of users.
Wow. And how exactly does an antidepressant stop an orgasm? What's the actual mechanism there?
Think of sexual arousal in the brain as having an accelerator and a set of brakes.
Okay.
Dopamine is the accelerator. It drives anticipation, desire, and physical arousal. Serotonin acts as the brakes. It promotes satiety and calm.
So they oppose each other.
Right. And SSRIs work by flooding the brain with serotonin to fight depression. But by keeping those brakes clamped down, they severely blunt the dopamine response.
Oh, wow. So the physical friction is happening, but the brain's arousal pathway is biochemically blocked.
Exactly. It's a chemical roadblock.
That makes so much sense. And the sources also point to menopause as a major physical cause, specifically something called genitourinary syndrome of menopause, or GSM.
Yes. GSM is driven by the severe drop in estrogen during menopause. Estrogen is what keeps vaginal tissues thick, elastic, and lubricated.
Right.
When it drops, those tissues literally thin out and atrophy. The nerve endings become less responsive, and blood flow decreases.
So again, the mechanical friction might be there, but the biological hardware is compromised, making climax incredibly difficult or even painful.
Correct.
And that's just the physical hardware. When I was reading the psychological texts from our sources, they highlight profound mental blockers like relationship trauma or this really specific phenomenon called spectatoring.
Oh, spectatoring is a fascinating psychological block.
Like, what is it exactly?
It's when performance anxiety causes a person to mentally step outside of their own body during sex. Instead of being present and experiencing the physical sensations, they are acting as a spectator.
Like they're watching themselves.
Exactly. Observing and judging their own performance, obsessing over whether they're taking too long or whether they are going to climax.
So they are entirely up in their own head. How does that physically stop an orgasm, though?
Well, when you are anxious, your brain fires up the prefrontal cortex, the logical worrying part of the brain.
Okay.
For an orgasm to occur, that specific part of the brain actually needs to quiet down and let the sensory processing areas take over.
Oh, I see.
If you are spectatoring, the anxiety literally hijacks the neural pathways, completely blocking the processing of the erotic physical cues necessary to push you over the edge.
Wow. So if psychological anxiety and systemic chemical blockers are the primary culprits for this dysfunction, it feels inherently contradictory that the most heavily marketed cure right now is a localized physical injection.
It really does.
Let's look at exactly what these clinics claim to be injecting, which leads us directly to the physical target of this deep dive, the G-spot.
Ah, yes. The elusive Grafenberg spot.
Let's talk about the history here because it's wild. This area was first described back in 1950 by a German gynecologist named Dr. Ernst Grafenberg.
Right.
But it didn't even get the name G-spot until 1981 when Dr. Beverly Whipple coined the term to honor him.
And according to the literature that supports its existence, it is an erogenous zone located about 1 to 3 inches or 2 to 3 centimeters inside the anterior or front wall of the vagina, right around the urethra.
Okay.
Proponents describe it as a highly concentrated, spongy area of tissue that actually swells and engorges with blood during sexual arousal, functioning very much like erectile tissue.
Okay, here's where it gets really interesting. When you look at the websites for the cosmetic clinics offering the G-shot, they talk about the G-spot as an absolute, undisputed anatomical fact.
Oh, they state it like it's textbook science.
Yeah. They portray it as this definitive button just waiting to be pressed, but then when you turn to the official medical bodies,
The tone shifts completely.
drastically.
Major organizations like ACOG, the Society of Obstetricians and Gynecologists of Canada, and the International Society for the Study of Vulvovaginal Disease, they all state that the exact anatomy size, and even the existence of the G-spot as a distinct organ remain scientifically unproven and highly controversial.
I saw one medical journal literally call it a, quote, mere marketing term.
Yeah, that was a strong statement.
They argue there is no distinct anatomical structure there at all. They say it's just a highly sensitive extension of the clitoral network.
Right, to understand that, you have to picture the clitoris not as a small external button, but as an iceberg.
Okay, I can picture that.
The part visible on the outside is just the tip. The rest of the clitoris actually consists of these large internal legs, or crura, that wrap around the vaginal canal.
Oh.
Many modern anatomists believe that when a woman experiences pleasure from the quote-unquote G-spot area, she isn't stimulating a separate organ. She is just stimulating the internal root of the clitoris from the inside of the vaginal wall.
What's fascinating here is the massive disconnect. You have medical science saying, we can't conclusively prove this structure exists in the way it's portrayed.
Right.
And simultaneously, you have a booming commercial industry built entirely around augmenting that exact unproven spot.
Which brings us to the mechanics of the G-shot itself. The procedure was originally invented by a Beverly Hills cosmetic gynecologist named Dr. David Matlock.
Of course it was Beverly Hills.
Naturally. And from a purely logistical standpoint, it is incredibly fast. We are talking about a 10-minute, non-surgical outpatient procedure done right in the office under local anesthesia.
From reading the clinic sites, it looks like they are just using the exact same dermal fillers people pump into their lips or cheeks. Are they really just treating the vaginal wall like a cosmetic facial touch-up?
Mechanically, yes. Most commonly, they inject a hyaluronic acid filler, like Restylane or Juvederm.
Got it.
Hyaluronic acid works by attracting and holding on to water molecules in the tissue, which instantly adds physical volume to the area.
Okay, and I also saw something called the O-shot mentioned in the same breath. Is that the same thing?
It's a similar concept, but a different substance. The O-shot uses platelet-rich plasma, or PRP.
Oh, the vampire facial stuff.
Exactly.
Uh,
That involves drawing the patient's own blood, spinning it in a centrifuge to isolate the growth factors, and injecting that plasma back into the tissue. The claim there is that it regenerates tissue and nerve endings, though again, the clinical data is highly debated.
okay. So the physical goal here, at least according to the clinics, is to take this G-spot area and expand it to about the size of a quarter and the thickness of a pencil eraser.
That's the target size, yeah.
The idea is to make it bulge out into the vaginal canal. It sounds like, taking a small, flat speed bump and turning it into a massive speed hump so that a car, or in this case, a partner, literally can't miss it.
That is an incredibly apt analogy for the physics of the procedure. The underlying logic is purely mechanical. A larger, more prominent physical structure will create more friction and receive more direct stimulation during penetrative sex.
The clinic websites quote pilot studies claiming an 87% success rate in enhancing sexual arousal and gratification. They feature glowing testimonials about instant results and intense pleasure. But the sources from the major medical boards paint a very different, much more cautious picture.
They do, and for very good reason. ACOG strongly discourages the use of these fillers for this off-label purpose.
Right.
These are medical procedures, and they carry risks that are often downplayed on slick wellness websites.
Yeah, the ACOG statement listed complications like urinary retention, scarring, pelvic pain, and something called fistulas. Can you explain what a fistula actually is? Because that doesn't sound like a minor side effect.
It absolutely isn't. A fistula is an abnormal, surgically created hole or tunnel that forms between two hollow organs.
Oh my God.
Yeah. In this case, because the anterior vaginal wall sits right up against the urethra and the bladder, a botched injection or a severe infection could literally create a hole between the vagina and the urinary tract.
Wow. So you could end up leaking urine into the vaginal canal.
Yes, and the anterior wall is a highly vascular, nerve-dense area. If the filler compresses the wrong blood vessel, it can cause tissue necrosis.
Which is what exactly?
It's where the tissue literally dies from lack of blood flow. It is rare, but the consequences are severe.
Okay, so we have the definition of anorgasmia and its chemical and psychological roots. We know the controversy of the anatomy, and we understand the mechanics and the physics of the G-shot.
We've covered a lot of ground.
We really have. Now, we have to put it all together to answer the core question of this deep dive for you. If you are a woman suffering from anorgasmia, is this injection a viable treatment? Let's start with primary anorgasmia. Someone who has never had an orgasm in her entire life.
The sources are unequivocalness. If a woman has primary anorgasmia, the G-shot is definitively not a suitable treatment.
Okay, full stop.
Full stop. Even the clinics that offer the procedure generally state in their fine print that it is designed as an enhancement for normal sexual function, not a cure for dysfunction.
So if we go back to the idea of the SSRI being a cut telephone wire,
Yeah, good callback.
if the neural pathway from the pelvis to the brain has never been established, or if psychological trauma has cut the signal, injecting filler into the G-spot is basically like buying a larger, louder telephone.
Exactly.
It doesn't matter how big the receiver is if the signal to the brain is completely blocked. Pumping the tissue full of collagen won't magically create an orgasm out of thin air.
That is exactly the right way to think about it. You cannot physically amplify a neurological reflex that hasn't been established.
Right.
For primary anorgasmia, the medical texts point to a completely different gold standard of treatment, which is directed masturbation.
And reading through the UT Labs text, the success rates for directed masturbation are staggering compared to almost anything else we've looked at.
They really are. Studies dating all the way back to Kinsey and confirmed by modern research show that directed masturbation programs have up to a 95% success rate in helping women achieve their first orgasm.
95%. How does that actually work, neurologically speaking? How does it fix the broken pathway?
It relies on neuroplasticity, basically rewiring the brain. It involves education, visual exploration, and guided self-stimulation in a completely low-anxiety environment.
So no pressure.
Exactly. Because there is no partner present, the anxiety of spectatoring is removed. The prefrontal cortex stays quiet.
That makes a ton of sense.
It allows the woman to establish a physical feedback loop with her own nervous system, without the sympathetic nervous system,
Yeah.
the fight or flight response getting triggered.
It's cognitive behavioral therapy, but applied physically. You have to train the brain to accept the sensory input without panicking. That is how you treat primary anorgasmia, not with a needle.
Precisely.
Okay, so primary anorgasmia is a hard no for the G-shot. What about secondary anorgasmia? What if you used to climax but lost the ability, or you only struggle with that situational coital anorgasmia we talked about earlier? Is it an option then?
Here is where a sliver of nuance exists, but it requires extreme caution. Some clinics will offer the G-shot to patients with coital anorgasmia, women whose specific goal is to climax during intercourse.
Right.
However, the absolute critical prerequisite is that the patient must already know from past experience that she highly enjoys deep G-spot pressure.
Because if she doesn't actually like that specific type of internal pressure...
It could be a disaster.
Oh, man.
If a woman finds deep vaginal pressure uncomfortable, irritating, or numb, making that specific area the size of a quarter so it gets rubbed incessantly during sex is only going to amplify her discomfort. It could make intercourse significantly worse.
And what if she does enjoy it? What are the realistic outcome goals if she goes through with the injection?
If we connect this to the bigger picture, we have to look back at the root causes we discussed in segment 1.
The SSRIs in menopause?
Exactly. If a woman's secondary anorgasmia is caused by the SSRI she takes for depression, or by profound relationship trauma, or by the severe loss of estrogen during menopause.
Right, the systemic stuff.
Yes.
Yeah.
Injecting localized hyaluronic acid into the vaginal wall is not going to magically cure a systemic chemical blockade or heal a psychological trauma.
It might temporarily increase physical friction for the 4 to 8 months that the filler lasts, but it completely ignores the underlying biology of why the system stalled in the first place.
Exactly. This is why the medical literature aggressively advocates for highly effective, non-invasive alternatives before anyone ever considers a needle.
Right. Our sources listed several that seem far more logical, like working with a doctor to adjust the dosage of the SSRI to let the dopamine system recover.
A much safer first step.
Or modifying physical positioning using something called the coital alignment technique, or CT.
The coital alignment technique is a fascinating behavioral intervention. It's an anatomical modification of the standard missionary position, where the male partner rides higher on the woman's body.
And how does changing the angle fix the problem?
It changes the geometry of friction. In standard missionary, the thrusting motion often bypasses the external clitoris entirely.
Which, remember, 70% of women need stimulated.
Right. In SIA, the partners lock their pelvises together, and the movement shifts from deep thrusting to a continuous rhythmic rocking motion.
Oh, I see.
This geometry ensures continuous direct friction against the external clitoris while still maintaining penetration. It maximizes external stimulation using pure physics without requiring any medical intervention or cosmetic fillers.
So what does this all mean? When we look at this massive stack of research, from the psychology labs at UT to the marketing brochures of Beverly Hills clinics, a pretty clear synthesis emerges for you.
It really does.
The G-shot is an unproven temporary cosmetic enhancement. Its sole mechanism is to increase physical friction by creating an artificial bulge in the vaginal wall.
That's the long and short of it.
While it might offer a temporary mechanical boost in sensation for a woman who already has normal sexual function and already knows she loves G-spot stimulation, it is definitively not a cure for lifelong primary anorgasmia.
Definitely not.
And for secondary anorgasmia, it completely ignores the complex psychological, chemical, and relational roots of the problem.
It is a localized anatomical attempt to solve what is rarely a localized anatomical problem, which actually brings up one final fascinating point from the research to leave you with.
Let's hear it.
We've spent this entire deep dive analyzing physical anatomy. We've debated the exact location of nerve bundles, the mechanics of dermal fillers, and the physics of forcing a physical reflex through enhanced friction.
Right. Everything has been about touch.
But nestled deep in the clinical texts is a finding by Dr. Beverly Whipple, the very researcher who named the G-spot back in 1981. In her later research, she documented that roughly 1 to 2% of women possess the ability to achieve profound, measurable orgasms through self-induced imagery alone.
Wait. No physical touch whatsoever.
None. Just the power of the mind and intense fantasy.
Are you serious?
Completely. And these weren't just subjective feelings where the women claimed they felt good. Researchers hooked them up to monitors and measured significant sympathetic nervous system activation.
Meaning what exactly? Like, what were they measuring?
Meaning their bodies exhibited the exact physiological markers of a physical climax.
Okay.
Their heart rate spiked, their blood pressure increased, their pupils dilated, and their pain thresholds skyrocketed.
Wow.
It was perfectly mimicking the body's fight-or-flight arousal pathway, but entirely triggered by the brain.
That is incredible. The hardware fired without anyone touching the keyboard.
Right. It forces us to ask a profound question. We pour millions of dollars into cosmetic injectables, searching for the ultimate key to human sexual fulfillment in the physical anatomy of the body.
Trying to find a shortcut.
We look for a button to press. But if a climax can be triggered entirely by imagination, with measurable physical results, is orgasm ultimately an anatomical reflex? Or is it a perceptual experience generated entirely by the mind?
You know, we started this deep dive talking about the appeal of a 10-minute cosmetic injection, that very human desire for a simple, binary fix to a complex problem. But the human body and the human mind just refuse to be that simple. Thank you so much for joining us on this deep dive. Keep asking questions, keep looking past the marketing, and keep exploring the fascinating intersections of medicine, psychology, and the human experience.